Welcome everybody to the last session of the afternoon. Thanks very much, and I know there are people coming in, but we've waited just a minute or two to start. This session will be on critical care systems. There's a terrific and diverse lineup of speakers that will come up to the stage. First is Charles Gomersall from the Chinese University of Hong Kong. And I've known Charles for a number of years, but I would like to read his official bio. I think it's actually much better. His only minor claim to fame is persuading a group of friends, or as they say now, ex-friends, to write the basic course, which is something that Charles has instituted for the teaching of critical care around the world, which has been run now in over 35 countries. That's just a terrific accomplishment to add to his many skills, research, education, and clinical care. Thanks very much, Charles, for being with us from such a long way away.
Thank you very much, Rob, and it's a great pleasure to be here. God, that's a really bright light. I'm going to talk about the outcomes of patients denied ICU admission, and the reason I get to talk about this is that I come from a ICU system where we turn down about 25% of patients that are referred to us, which is a fairly unusual situation. But does give us some opportunities. Now, why are we interested in patients who are refused admission? Well, first of all, it will give us, or may give us, some estimate of the magnitude effect of ICU admission. You know, we all assume that being admitted to the ICU makes a difference. That's, if we didn't, we wouldn't be here, we wouldn't be going to work. And also it's quite important for triage. And now many of you will be aware that there are recommendations for how to triage. CCCF have them, and they have a number of priorities, with priority 1 being critically ill, unstable patients who need treatment and monitoring that cannot be provided outside the ICU, and it goes from 1 down to 4. Now, the underlying premise of this is that you should admit those patients that will benefit most. And it's assumed that priority 1 patients are the patients that will benefit most. And that's fine if you are looking at patients throughout that range. For us, we're actually choosing from within priority 1. So it doesn't help us very much to say we'll only look at the unstable patients, because those are the groups we choose from. If you weren't unstable, if your patient wasn't unstable, why did you ring me? Is essentially the response that we will give on the telephone. So the issue then really is a question of benefit. Well, what is benefit? Now, of course, there are many dimensions to benefit, but the easiest one to look at is survival. Now, typically, benefit from ICU is taken as being equivalent to survival. So if you have a high survival rate, then you have a lot of benefit. If you think about it for more than about 30 seconds, that obviously isn't true. It's like saying the benefit of an ACE inhibitor, well, actually, no, that's not a good example. Benefit of an antibiotic is the survival if you receive that antibiotic. But we know full well that a large percentage of the patients would survive anyway. And it's really the incremental survival that's the benefit in ICU. So in the terms of triage, what your benefit is the increase in probability of survival associated with ICU admission. And if you want to think of it in very simple mathematical terms, then your benefit is the probability of survival in the ICU minus the probability of survival on the ward. Now, how does that help you when you go and see the patient, when you're choosing who to admit? Well, you've actually got to know this value, haven't you, if you want to be able to choose. You've probably got a rough idea about this because you see patients in your ICU all the time. But unless you're following up your patients that you turn down, how do you know about this? And for us, that's why what happens to patients who refuse admission is really important. Can we tease out how are these patients going to do? Can we predict who's going to die if left on the ward and who's going to be fine regardless of whether we admit them to the ICU or not? Well, we looked at this some time ago, and we looked at doctors' gut feeling, because in the end, that's generally how we do it. We go, we look at the patient, think, going to do well, going to do badly. It's a gut feeling. So we asked the generally residents who saw the patients on the ward to give a prediction of the patient's probability of survival if admitted and the probability of survival if left on the ward. And then we, at the same time, collected quite a lot of data to see if we could develop a model that would predict this. Now, many of you will be aware that there's generally recommended that you don't use scoring systems for triage. And the argument is that most scoring systems are not well calibrated. So in other words, if you say that the probability of survival is 50%, is it 40% or is it 60% or is it 30% or is it 70%? The calibration is generally not very good. Which begs the question, well, what is not very good? And the more important thing is it better than what we do now? And so that's why we looked at the calibration, both for gut feeling and for our model. And you can see for gut feeling, if the calibration is good, the orange bars and the purple bars should be of equal height throughout the range of deciles of risk of mortality, risk of death. And you can see that gut feeling really pretty bad in the middle. The model's a little bit better, but still not very well calibrated. But the important thing is, as I say, is this gut feeling. We're not good at predicting what's going to happen. And it's not surprising we're not good, because we don't know what are the factors that predict the outcome of patients who are left on the ward. So what we've done is an observational cohort study of all adults referred for admission to the ICU. We have data both on those who are admitted and those who are refused, but I'm only going to talk about those who are refused. I should emphasize this is a single institution study, which has a lot of implications because care on the ward, of course, varies considerably from hospital to hospital, and certain hospitals be good looking after certain sorts of patients, and other hospitals be good looking at others. So all this is really going to do is give us an idea of what sort of factors we should look at if we're going to study this across a range of institutions. It is also a particularly somewhat unusual institution, particularly compared to, I believe, Canadian ICUs. It's a tertiary referral university hospital. There's the referral hospital for trauma, cardiothoracic surgery, neurosurgery, hepatobiliary surgery, and burns. It's a 1,400-bedded hospital with only 22 ICU beds. The local population is 750,000, with a referral population of 1.5 million, and we take all patients who need intensive care, or all patients we're able to admit, who need intensive care are more than 12 years old. So in that ICU is general medicine, surgery, trauma, cardiothoracics, neurosurgical, hepatobiliary, and burns. We asked for these patients that were refused admission, they were categorized into those who were considered too well for admission to ICU, those who were considered futile or too sick, and those for whom we thought that ICU was appropriate, but we were going to choose those who derived the greatest benefit. And you can see the numbers of patients, and you can see the predicted mortality based on MPM20. And you can see that we sort of, as you would expect, you expect a gradient of severity from the least severe to the most severe as you go from well to futile. You can also see, though, how bad we are at determining people are futile. patients are futile, because in the futile group, the mortality is about 80%. Now, nobody would say a 20% survival makes treatment futile. The other interesting thing is you can see that our patients are really quite sick. Some of you will have heard Hannah Wunsch present data from the US indicating that a large proportion of patients admitted to the ICU in the US have a less than 2% predicted mortality. So the ones we're calling too well have a 20% predicted mortality. If you look at the actual mortality, though, this is rather more interesting, because you can see, not surprisingly, the actual mortality, if you leave the patient on the ward, don't admit them to the ICU, is going to be higher than the predicted mortality based on assuming you admit the patient to the ICU. But it's this group that are the most interesting, because the actual mortality is in fact lower than the predicted mortality, even although you don't admit them, which is why the SMR in this group is about 0.6, whereas it's over 1 in the other two groups. Now, what I think this suggests is that possibly in the patients that are relatively well, being admitted to the ICU makes you worse. And there are other data that support this. There's a study from Australia looking at patients who are referred to the HDU but don't get in, and those that actually get into the HDU do worse. And it may be that what we do is we fiddle too much with a patient that's not that sick. We treat them like a sick patient, and we actually make them worse. Now, this is partly supported by previous data of ours, where we looked at this is the observed mortality against the NPM20 for patients who are admitted, admitted, and those that are refused admission to the ICU. And again, you can see there's a separation between the two curves that's greatest in the mid-range, but almost it disappears at the bottom end. Now, of course, you have to bear in mind that it's possible the NPM20 is just not well calibrated at this low end, and that explains that the lack of apparent benefit from the ICU at that end. But it does make you wonder whether we're actually making these patients worse. Now, if you look, we followed up the patients that we refused. It's basically, we studied them, we collected data for 6 years, and we followed them up for up to 10. And you can see that there is a difference in those that are too well, those that were triaged, and those were considered futile. But again, you can see that we're not very good at determining patients are futile, because way out here, at 10 years, there's still about 20% of them alive. This is very busy, and I apologize for this, but this is data from the Eldicus study. Again, you can see that here there's a too ill group, a too well group, and a group they call no beds, which I've assumed is their triage group. I'm not quite sure how you triage when you have no beds. We specifically don't collect data when we are absolutely full and there's no patient who can be transferred out, because we don't think there's a decision to be made. Even if I want to admit the patient, I haven't got a bed to put them in, so there is no decision. Anyway, the important thing is that you can again see that although not being admitted to the ICU may well reduce your chances of survival, it's by no means a death sentence. Okay, the mortality when you take the patients who are turned down because there are no beds is 27%. So either these patients are all inappropriately referred, and they're probably not, because otherwise they should go into the too well or too ill group, or it really isn't a death sentence being refused admission to the ICU. Now, when we looked at our data, unfortunately, I've only had a chance to do a univariate analysis so far. As you can see, I'm very slow because we've been doing the study for 10 years. But as I say, we've only got univariate analysis so far, and it's sort of pretty much the obvious things, age, low GCS, intracranial problems, if you have CPR and you don't get admitted to the ICU afterwards, then you're not going to do well. Requirement for immediate ventilation, I'll come back to that. Non-operative patients, bedbound patients, people with impaired activities of daily living, cardiac arrhythmias. Hepatitis surface antigen positive is probably a Hong Kong thing. Hepatitis B is quite common in Hong Kong, and that probably just ties in with cirrhosis and chronic renal failure. Those that are not associated with death are gender, where you are when you get referred, surprisingly metastatic cancer, coffee grounds in the nasogastric aspirate, I put in there as being surprising because it is part of MPM as a predictor of poor outcome. We have previously shown that it is associated with poor outcome in refused patients, heavy alcohol consumption, and whether you're on NIV at the time you're referred. Now, I said I'd come back to the issue of mechanical ventilation. This, for me, is really what some of the more interesting, is one of the more interesting findings, because one of the data points where the doctor seeing the referral was asked to collect was whether the patient, in his or her opinion, needed immediate mechanical ventilation. And you'll see that out of our about 1,470 patients, about half were thought to require immediate mechanical ventilation. They didn't come to the ICU, so they didn't get ventilated, or they certainly didn't get invasive ventilation. And the mortality is 69%. But more importantly, turn that around the other way, that's 31% survived. Part of it is related to NIV, but even if you take the patients who didn't receive NIV at any time, 22% of patients judged to require immediate mechanical ventilation survive. This suggests to me that we grossly overestimate or not grossly, but we do overestimate the efficacy of our invasive organ support, and it may not be quite as effective as we think. Now, so far I've just talked about patients who were refused. We do have some data from an earlier data set where we looked at all patients over a 7-month period who were referred for admission, and we divided them into 2 time periods. And from the first 4 months, we collected data on severity of illness, diagnostic weighting from the Apache 2 score, age, sex, and delay between hospital admission and ICU referral as a surrogate measure of response to treatment, on the basis that if it was a long delay, you probably weren't responding to the treatment. What we found, well, the independent predictors of survival were age, your severity of illness, and whether you were admitted to the ICU or not, with an adjusted odds ratio for survival of 2.18. Again, perhaps not surprising that ICU admission is associated with improved survival, but for me it was a surprisingly small number. You're only doubling the odds of survival if you come to the ICU. My turn. Okay. So let's just skip through that. All right, now, if you look at the ELDICUS study, you'll find here is the adjusted odds ratio for mortality if you're refused admission to the ICU. You'll see it's not significant, suggesting in that study that ICU is not having an effect on survival. Now, I think the reason for this is because of the distribution of their patients who are refused admission. In our group, the majority of patients who are refused on the basis of triage. We think they're not too well, not too ill, but we just don't have a bed for them. So these are patients we think will benefit. In the ELDICUS study, the majority are either too well or too ill. Now, when you say too well or too ill, presumably you mean too well or too ill to benefit. So therefore, it's not really surprising if this is your group that you analyze as being refused admission to the ICU, you're not going to show a benefit from ICU, and that perhaps if they just looked at this group, they would have shown that ICU is associated with an increased chance of survival. So to sum up, the impact of denial of admission isn't a death sentence. There's substantial survival without intensive care. However, certainly our findings may be institution-specific. Mortality is probably increased, but perhaps not in the less sick patients. Thank you very much for your attention.
We have time for a question if anyone wishes to come up to the microphone. If no one does, maybe, Charles, I can ask one question. I recently read a perspective piece that was published in the New England Journal, and it was written from the perspective of a former house officer in one of the Boston hospitals, and spoke about their cultural experiences working in East Asia and Southeast Asia, and talked about admission to ICU to fulfill what was called a sort of debt of life, I think was the terminology, in terms of the family wanting to do everything that they could do and to demonstrate that in some very tangible way. Is that something that you encounter, even in cases that you think probably too ill to benefit?
Yeah, absolutely. If we talk to a family about not coming to the ICU, typically it's a decision based on triage, that we think that the majority of them we think will derive some benefit. And you can see the data suggests that we really, even those you think are futile or too well are not that well and not that sick at the two ends. So in a sense, all of them are actually triage. And we have developed a policy of being very frank with the family. If I try and dress it up as, oh, look, Granny is not going to benefit, her chances of survival are low, the suffering is just not worth it, the family will invariably say, no, we want to take that chance. Okay? And this is partly driven by this concept that we refer to as filial piety, where you're supposed to do the best, the inverted commas, the best for your family. If we say to the family, listen, Granny's got a small chance of benefiting, and we need to keep that bed for someone with a bigger chance, the response of the family is invariably, well, that's okay then. And it's a very, very strange thing because, I know if I tried that in London, the MP would be on the phone in under 20 minutes saying, what the hell do you think you're doing? But in Hong Kong, that's an entirely acceptable thing to do. But saying, on an individual basis, the suffering benefit ratio is not sufficient to admit your grandmother. The response will always be, we'll take the chance, however small.
Thanks very much, Charles.
Good afternoon. My name's Good afternoon. My name is Tom Selfox, and my colleague is Rob Fowler. We have the privilege of introducing Dave Zygun next. So I actually knew Dave. We were both medical residents before he became famous. Since then, Dave's gone on to do critical care in Calgary, neurocritical care at the University of Cambridge. He's now professor and head of critical care at the University of Alberta, as well as a senior medical director of the Critical Care Operational Clinical Network in Alberta. And he's here to talk to us about queuing in the ICU.
Thanks, Tom. Interesting that my former senior residents are to my left here at Sunnybrook. So I'm going to talk a little bit about ICU queuing and what that means for us and our patients. Well, actually, that was assigned. What I'm actually going to talk about is, since I took the both zone department head and the provincial job, we don't have enough ICU beds. I hear this all the time. If we just had more ICU beds, everything would be all right, because we could admit the patients, we could discharge them, our jobs would be lovely. And yet when I present that to the people who control the budgets, they don't necessarily believe that. And so they ask, how many is the right number of ICU beds? So we're going to talk a little bit about counting ICU beds and what's out there to try and determine what the right number is. And I hope I'll convince you that we should probably stop doing that. We're going to talk about the consequences of having the wrong number of ICU beds and why it's important to examine this. And really, we have to have a discussion about ICU as a scarce resource and really what the risks and benefits of for having too little, but also too many within our system. Dr. Garland and his colleagues in Winnipeg has actually produced the latest ICU count. They did it from Manitoba. The data they had went up until 2007 and looked at really the epidemiology of these units and the patients that are using them. And so Manitoba had a population of 1.2 million in 2007, and they had 118 ICU beds. So that's 9.8 beds per 100,000 population. What about Alberta, where I'm from? Well, we have, here's our provincial data. Now it gets a little bit interesting. The red is where we consider a broader spectrum of ICU beds. So that includes all of our burn beds that are at 1-to-2 ratio, our neuro beds, which are variably ICU 2 and 3 beds, as well as our CVICU. The beige is the general system. So, you know, if you're living in the north zone or in the central zone, you seem to be below NHS standards for number of ICU beds. But then if you're sitting in Edmonton or Calgary, you're closer to what's being reported in Manitoba. Well, we've seen this several times already in this room during this day by Wunsch et al. Back in 2008, where investigators from each country did a lot of work to try and actually decide how many ICU beds they were. Are you in the UK, where they're down in the 3s per 100,000 population, or are you up in Germany? You see the US there way off to the side with clearly a higher proportion of ICU beds per hospital bed than anywhere else. And we're kind of somewhere in between, typical for Canada. Now, this is what I really like, and especially the use of lines, because if you look at intensive care beds per 100,000 population and ICU mortality, you will see that if you extend that line out to 50,000 or 50 per 100,000, we will cure ICU mortality. It'll be great if you just build more and more ICU beds. Of course, a line may not be the best way to model that for obvious reasons. And further, this is an ecological study where they chose some databases suggesting mortality and tried to align it with beds per 100,000. And nowhere does it say which one of those numbers is right, nor did the authors claim that. And really, when we get into counting beds, one of the main problems is, what is an ICU bed? And it's very interesting. In this study, they actually showed that they tried to capture all adults. Some included high dependency or level 2 type beds. Some included CCU beds as their critical care base. And really, it is challenging to equate different operational models. Indeed, while I've tried to do this in Alberta, you get into various different names. So if you look in the Schedule of Medical Benefits in Alberta, you will see the notations for ICU 3, 2, and 1. And nowhere is there actually a definition of what that is in that document. People variably use HDU, HIU, step down, step up, high observation, close observation beds. Well, what are those? Are those all ICU beds, or where do we draw the threshold? Importantly, as you actually go to these sites and you actually recognize what makes sense in their operational model, in a small community hospital might be very different from your big tertiary hospital. And so, quite sensibly, they've combined ICU and CCU beds and used them operationally in a very efficient manner. How do specialty critical care units play into that? Especially when they try to span the continuum of care from ICU 3 and rotate the care around the patient to right until they're on the ward and receiving their rehab. Is that good care because we're rotating the care around the patient, or are we keeping patients in ICU resources? Further, let's talk about the denominator. Okay, so my center, we cover transplant for parts of Western Canada and all of Alberta. We certainly have other specialties that do that, but we also have very local primary critical care as well in our unit. So what's our denominator for those specialty type services? It can be very difficult. For those of you feeling sorry for the central zone and the north zone, as you can imagine, as in many places in Canada, much of the ICU does get referred down to the major tertiary centers. So that facilitates obviously things like having a neurosurgical service at one center and not 12 centers, because it's not really needed at 12 centers. So even the denominator is tough to define. And so I think that counting beds and comparing between jurisdictions, you really have to understand all of those definitions, all of those operational models. And by the time you try to understand it, it's changed because people are very fluid within their systems. Well, okay, if we don't know the right number, let's start with the UK and say what happens when we actually increase ICU capacity. And this was published in BMJ back in 2009. And what they did was they reviewed their critical care services. They certainly recognized, as we all do, that they were underserviced compared to other jurisdictions with respect to number of beds. So they were up there in the 3 per 100,000. And they made a clear commitment to increase that capacity. But they did far more than that. And they formed networks. They formed the ability to examine care and provide things like ventilator bundles and ensure that ICUs were doing that. And you see the timelines on there. What resulted? Well, they certainly increased the absolute numbers of beds. But you'll see there in the light blue and the dark blue that the proportion of beds in either mixed units or just high dependency, so not necessarily the ICU 3, was really where they expanded their absolute numbers. And what did they do when they did that? Well, they certainly showed that they reduced readmission rates. And importantly, after about 2003, you see their mortality starting to decline. Now, interestingly, that wasn't necessarily aligned with the increase in ICU beds, but more so the evidence-based protocols like the ventilator bundles. And of course, as you'd expect, there was a variable timing with adoption of these best practices. So suffice it to say, when you're at the low end and you not only increase your capacity but include a number of other interventions, which in this study can't be really separated, that they do see some positive events. This, though, doesn't really help us on the other end, how many ICU beds may be too much. Because of this huge geographic variation in the number of ICU beds, really from about 3 per 100,000 to 25 per 100,000 in Germany, it really begs the question of whether or not there is an optimal provision of ICU beds. And what are the consequences to society in terms of having either too few or too many beds? I think it's something that we have to consider. Well, let's talk about too few beds. So we've heard a little about refusal to ICU. I'll summarize that, but go off to delay in ICU admission, which is something that I think that we should maybe focus on as opposed to the absolute number of beds, and also premature discharges. Well, this systematic review kind of summarized the literature pre-2004 with rationing or limiting of ICU capacity. They actually had multiple studies that included those that both rationed critical care beds but also triage decisions, and that's one of the limitations of this literature. Are you actually triaging or actually rationing? They tried to separate it up. Needless to say that refusal to have ICU admission was associated with a higher death rate, although as Charles has pointed out, not necessarily 100% fatal there at all, but a mixed effects model of a ratio of 4 for death. Well, to try and get away from that mixed picture, they tried to get, Robert and colleagues in France studied 10 ICUs in their admission practices purely due to having a full unit, so capacity strain issue. Fairly reasonable sized study with a number of patients, almost 200, could not be admitted immediately. And some of those patients did get into ICU, but a portion also didn't eventually. Well, what did they found? Ultimately, both at a shorter term, 28 days, and later at 60 days, a 6% absolute difference in mortality, whether you got admitted immediately or had some degree of delay due to capacity concerns. If you like survival curves, there's a survival curve, separate pretty early as you'd expect, and the separation continues. Well, this is a study that was published in Critical Care in 2011, and essentially it's a single center study and looks at delayed admission. So all of these patients were patients who were referred for ICU, in which the intensivist felt that the patient could benefit from ICU. And due to severe capacity constraints in this country and hospital, there was actually the majority who had delayed admission. And as you'll see, that even if you've had delayed admission, you certainly can survive. But at least in Univary, it's at a lower rate than if you received immediate admission. You'll note that these patients were sick, Apache 2s of 26. Also note that although it didn't reach statistical significance, there's a median 1-day length of stay improvement if you're admitted early. And you'll see this through these studies is that if you tend to delay ICU admission, you end up paying for that capacity down the road with longer lengths of stay in your institution. There seems to be a dose response curve. All these patients were said to need ICU, and sure enough, the longer you wait, mortality increases from a baseline of 37 all the way up almost to 60% if they had to wait more than 24 hours. And those patients were re-looked at and reconsulted on over time. Well, what about multivariate analysis? And it looks like the increased hazards are about 1.5% per hour waiting for ICU in multivariate analysis. So, we've kind of quoted per hour mortalities in things like transected aortas or ruptured esophagus, but it's probably relevant to waiting for ICU as well. Well, that's all comers, but what about by site? Because, as was mentioned earlier, the reality is if we're full and we're full, there's not that many decisions to make, but we do oftentimes keep patients in various locations to try and buffer that capacity strain. One of them is in the post-operative recovery. I'm sure if you've worked in Canada, you've left patients in post-op recovery for hours and days and had anesthesia yell at you and be upset at you, and some patients even stay their whole ICU stay there in severe capacity strain. So this study looked at delayed ICU admission, particularly from the operating room. And so these patients would stay in the post-op recovery area. Hey, they have ventilators. They have anesthesiologists. Well, how do they do? Interesting, although there was a 0.6 day median ICU stay difference, it didn't reach statistical significance, nor was mortality significantly different. Now, patients who were delayed did require advanced respiratory support, so invasive mechanical ventilation a little bit longer, but overall that didn't affect their length of stays. So it really depends in capacity strain where your patient is, and also obviously the quality of care that can be provided in those areas to buffer some of the effects when your unit's under capacity strain. Well, what about the medicine and surgery wards? This is where we really worry about it, right? In Emerge, you got an Emerge doc, and they can run ventilators and post-op. But when you're on the wards, and all you have is you and maybe your outreach nurse and RT, you need a bed. And in this study from Montreal, single center study, indeed, from the time of physiologic deterioration to the time of ICU involvement in this study by MET criteria, the longer that was, the increased mortality for medical patients. Interestingly, that was not found in surgical patients. Length of stay data was variable. In fact, the surgical patients, although they didn't experience a mortality decline with waiting, they did experience an increased length of stay as a result of delayed recognition and entry into ICU. In another single center study by Young and colleagues, again, a fairly dramatic mortality and dependency at discharge difference between those that were admitted immediately versus those that had delayed. And I believe this study had a 4-hour threshold for the delay. Also had length of stay increased when delayed, as well as hospital cost when ICU is delayed. It begs the inference that, well, maybe you're not paying for the capacity up front, but you may be paying for the capacity at the end, as these patients have to stay longer due to waits in. Well, this study, actually by my colleague Tom, really kind of woke me up to what may be happening out on the ward. So they did a large study from the Calgary region looking at MET activations and bed availability. And they really didn't show huge differences in mortality at full occupancy. But what they did clearly show was a change in level of care, or philosophy of care, goals of care, with more patients being changed to less aggressive models of care provision when we were at capacity. Now, maybe that's because physicians were, overutilizing ICU resources. When we had a bed, let's just admit that patient, but maybe they got up and did have those goals of care discussion more frequently when we were at capacity. But we'd hate to think that we're making patient care decisions based purely on capacity. Well, there's my one of the representative units in Alberta. This is our historical dashboard looking at occupancies. We're at continuously high levels of occupancies. So what these are is hours at your maximum occupancies, and those red lines are your maximum occupancies. And the monthly data shows that 100% occupancy is quite frequent, especially in the fall. You see there in February that the majority of days we reached 100%. And when we were there, we were at there for 21 hours of the day. So we continuously operate at high occupancies. In Emerge, it's the same story. I'm running out of time, so I'll skip by this. But also from emergency, even though they have ventilators, they resuscitate patients. This study showed that a delay in ICU admission for greater than or equal to 6 hours was associated with higher ICU and hospital mortality and higher lengths of stays. And this held through in multivariate analysis as well. Although the data is not always in the same direction. Here's another study really showing no effect. And of course, to get into this, you'd have to understand what care can be provided and what kind of the environment is there under capacity strain. Lots of other studies, probably increasing the risk of premature discharge, increasing the risk of readmission. Wagner has recently published this year on that. Increase the risk of discharge during off hours, and certainly in Alberta we're seeing higher and higher rates of that. And lots of other things have been demonstrated, including increased hospital-acquired infections, lower hand hygiene compliance, higher risk of post-operative complications have all been identified. If we look at the strained intensive care units, interesting, even our models have to come under question. So this recent study showed that, and this was from Impact, showed that under capacity strain, that in fact closed ICU models saw a higher odds of mortality than open. And the authors postulated that that's maybe because under strain, the open ICU had more hands available in that. Well, if you look at where unit refusals will have, you can look at some of the queuing theory data, and this study by McManus showed that really if you wanted to prevent refusals from ICU, your ICU utilization is not going to be at 80 or 75%, but probably down as low as 60% to handle the strain in that particular unit. This is a single-center children's hospital. Of course, it would have to be modeled for each individual unit as they're quite different, but certainly utilization will have to be much lower if we want to prevent any degree of capacity strain. And given that many of our units run at 90, 95, 100%, that's a lot more ICU beds than we have. And are there risks of too many ICU beds? Well, certainly there is concern of unnecessary or inefficient use of intensive care and delayed ICU discharges because ICU has the capacity but the wards don't. There is obviously concern that dying patients may be more likely to be exposed to discomfort of ICU at the end of life. I think the big thing is, though, we have to think about the opportunity cost with resources in this resource restricted. So if we're spending our money on ICU, which is anywhere from $750,000 to $1 million a year, what are we not spending it on? And perhaps those interventions could have greater effects on ICU usage. So what do we really have to bring to the table? I think that clearly rationing, there's enough evidence that it occurs, and right now it's non-transparent. It seems to be non-random. It's maybe associated with ICU capacity strain, and I worry about the influences of quality care. I think we really have to decide, is ICU a scarce resource? Can we continue just to build larger and larger ICUs at those high costs? If it is a scarce resource, then we have to come to some triaging decisions, and I think that those discussions have to have in forums like this with our colleagues in critical care, with society perhaps most importantly, but probably shouldn't be left to the clinician at 3 a.m. Where they should be focusing on the appropriate medical care. And right now, we don't really have those supports in our system to provide those medical providers and families with very difficult decision supports, especially in very short periods where we have sometimes to resuscitate. Thank you very much.
Thank you, Dave. I think just to make sure we stay on schedule, what we'll do is we'll hold questions now maybe till the end.
So even if you are one of the lucky few to make it into ICU beds in Canada, once you get there, the next two speakers will speak about whether or not the doctor that you find at the side of your bed makes a difference or not. Andre Amaral is an intensive care doctor and quality improvement specialist at Sunnybrook Hospital here at the University of Toronto, and he will speak about the benefits or harms of having a different doctor in your bed, at your bed, every night.
Hopefully not in your bed.
Not in your bed, okay.
Oops. Oh, I can't see
You can
anything.
spice it up a little bit.
Well, thanks a lot, Rob, for the great introduction. So I'm going to talk a little bit about this, but I want to ask the audience a few questions, and just to get a sense of whether you're actually going to answer or not. Who works here or intends to work in the near future in an ICU? Raise your hands, please. Okay, so this is a good audience, so you actually answer. Who has received any formal training on handovers during your training? A few people. Who uses a standardized handover? Very few people. And who uses an electronic handover too? Well, I can't see well without the light, but probably not a lot of people. Now for the really important question. Who was able to buy tickets for FIFA today? That doesn't resonate in Canada. I knew that. I bought mine though. But here's, seriously, who has received a handover that really, really sucked? Raise your hand. Okay, so that resonates with you. Perfect. So if you have, you might think that, well, if I received a handover that really sucked, I didn't have enough information, so I'm cross-covering a patient, I could potentially be harmful. Does that resonate with you guys as well? Raise your hand if it does. Maybe, all right? So I want to review a little bit of this. There's a huge literature, so I'm going to review that with us. And then I want to understand what happens differently at night if, when we're cross-covering, if anything. And then I'm going to give you some novel data on how these differences could actually impact patient care. So to reveal it, I think we have this bias amongst ourselves. There's a lot of data from malpractice claims showing that about a fourth to a fifth of malpractice claims in diverse areas are associated with handovers. Handovers also may contain what people call errors or surprises, so incorrect information or information that was just not there. And trainees usually will tell you the next day when you come and ask them, how was your night? They'll say, well, there are a lot of things that happened and I was not prepared for those things. And maybe I should have been prepared. You know, now that I know what happened, I could have been prepared before. So handovers, there is a lot of literature showing all this. And lots of data also showing that medical history is missing, key active issues, medications, advanced directives, lots of things are missing from handovers. And I'm going to just spend a few seconds on why is it missing. One of the things why is it missing, and it does relate to communication. Handover, even if you use a standardized tool or an electronic handover, it comes down to people communicating. And this study is very interesting. They actually looked at diverse dyads of people communicating about patients that were being transferred from the Emerge to the internal medicine ward. And they asked both participants of the communication, so the receiver and the sender, what was the most important problem for that patient that was going to be admitted. And the agreement amongst all those patients on just one thing, what is the most important thing for those patients, was about only 50%. So that's a bit scary. I'm just asking what's the most important thing. But interesting, when this communication was done from a PGY1 to an attending, almost 80%. So apparently PGY1s are very good at communicating what the problems are. And when we saw the reverse, when the attending communicated to the PGY2, it was the other way around. So it's interesting because this communication, there may be many reasons for this. One of them may be attendings suck at communication. The other thing might be attendings don't need a lot of information because they're experienced and they can kind of understand the patient even if the information is not perfect. And this has been replicated in other settings. This one is interesting because they also show that in a pediatric setting, about 60% of the patients, they could not agree on the most important problem. But more interesting is what I call the mental model of who's actually communicating. So they looked into whether the patient making the communication was a pediatric resident or a resident from a different specialty rotating in pediatrics. And if they were from a different specialty, they were way more likely to miss the most important problem. So that highlights that if you actually know what you're talking about, even if the information is not great, it's easier to know. If you participate from if you're coming from a different mental model, you may be more likely to miss it. And for us, especially in academic hospitals, it's very important, especially when you have people rotating the ICU that have many diverse backgrounds. So for example, at Sunnybrook, you go now and probably have an orthopedics, an obstetrics, a ENT physician, an anesthesia, and an internal medicine rotating right now. So it is very likely that they won't be able to communicate well because they have different ways to think about patients. And this all leads to, probably this is the best paper, it's a 93 paper on adult internal medicine showing that when people are cross-covering, they lead to more adverse events. So what they did is they asked on the next day, the person that was taking care of the patient continuously, whether an adverse event occurred at night or not. And then they did a case control study and identified that if the person taking care of the patient at night was a cross-covering physician, cross-covering being defined as I'm taking care of you, but I did not participate on the decisions during rounds about your care, they were 6 times more likely to have an adverse event. So what happens then at night? So we have all this body of evidence that kind of says, well, communication sucks. Because communication sucks, maybe there are adverse events and malpractice claims. But what is it that happens at night that leads to problems? I guess the best study to look into this, and you might be well aware of this data, is the Landrigan study about trying to reduce the time, reduce errors by reducing interns' time working in the ICU. So instead of doing a shift for 24 hours and staying the next day, you're only allowed to do 12 hours or 8 hours of a shift. And this was associated with a reduction in medical errors. But I'd like to call the study the tired resident versus the misinformed resident. because I think it does, if you really dig into it, it has more information in its appendix that is actually quite revealing. So the tired is, of course, the person working 24 hours, and the misinformed is the guy that just jumps in, has to receive a handover, and may not know their patients very well. And if you looked at the types of errors that they did, it's actually fairly interesting, because if you look at wrong dose of a medication, you see that the tired did a bit more errors than the misinformed. But if you look at wrong drug, the misinformed did a little bit more than the tired. So I think this is interesting because those problems lead to different solutions when you're working in the ICU. So this is one of our tired residents or fellows at Sunnybrook working very hard and basically writes a wrong dose. Fortunately, there is a safety network. The nurse at the bedside will catch that problem and it will immediately be fixed. However, the wrong medication is a little bit more complicated because a safety net for a wrong medication, for a wrong diagnosis, is harder to capture. So this is a real example of a patient that unfortunately I did a bad handover and adverse events happened. So this is a 58-year-old lady with SLE and end-stage renal disease whose antihypertensives were being constantly held during dialysis due to hypotension. Later during the day, the patient would become hypertensive and was treated with hydralazine and became very tachycardic as a response to hydralazine. And this is her chest x-ray after dialysis and after removal of a lot of fluids. She went into pulmonary edema and was intubated a few hours later. And the thing is, oops, I forgot to tell you that she has severe mitral stenosis and the very high heart rate was very bad for her and she went into pulmonary edema. So this actually happened a few times with this poor lady coming back on and off from the ICU. So it is harder to capture those things because they're not immediately seen in the chart. So it makes sense that being misinformed might lead to adverse events. So one of our previous fellows decided to look at this, and we said, okay, this is a great opportunity. At Sunnybrook, we do have 2 people on call during the day and only 1 at night in the main ICU. So at night, it may be one of those 2 on call. It may be someone else coming from a different ICU, maybe from one of our step-down units. So there will always be patients that are being cross-covered. There will always be a handover. And if there is a continuity person, maybe half of the unit will not have cross-covering, but a continuity person. And we defined a few objective and concrete things we could measure from charts and said, well, what happens different? And do those people coming in at night and cross-covering, do they do more things or less things? And it turns out they do more things. So the total number of actions is basically double when you have a cross-covering person. A cross-covering person is doing more at night. And what is it that they're doing? They're changing the plans to extubate our patients. I told you to extubate, they don't extubate. They change mechanical ventilation. They give more antibiotics. They get more CT scans. And this is all quite novel and interesting, and I was very excited to see the data. I said, okay, great, let's get this published. So overwhelmingly, the reviewer said, but this is good or bad? I said, well, this is not designed to see if it's good or bad, just say that it's different. And I also responded, well, being different, probably one of them is bad. I don't know which yet. The whole literature says probably that cross-covering is bad, so maybe that's the one, but I can't prove. And I thought this was brilliant because it's different, it's bad. Unfortunately, they didn't think it was brilliant, so I didn't get this published yet. But I said, well, this is so novel and interesting. Let's get some more data so that at least this data also gets in a curious place, in a good place. So, and the problem comes from this study, which is the only study in the literature that suggests that actually a cross-covering person may be a good thing. So this is a study that's 30 years old. And they looked at incidents when an anesthesia person comes in and relieves the other anesthesia guy. So they found about 35 incidents or things that happened after the relief of the previous person. And although there were some unfavorable, most of them were highly favorable. So this is the only evidence in the literature that suggests that it may be good to have a new pair of eyes. Everything else says it's not. I said, okay, good, there's one. Let's try to generate more evidence. So this is basically the results of me with a medical student trying to get some more data to convince that maybe there is a problem with cross-covering or not. So we went back to the Peterson trial, which was the best evidence so far about creating adverse events with cross-covering people. And we actually thought back and said, well, they are actually telling us that the cross-covering person did something wrong. But there are other possible answers for this results. One of them is maybe what they're calling an adverse event is just because the person that came at night actually did something different than they were doing, but that thing is actually the right thing to do, and they didn't recognize it yet. Maybe the daytime person is actually wrong. Or this is all hindsight bias. Because I'm coming the next day and I'm seeing what already happened, I kind of know it. So let's review hindsight bias. Where's Waldo here? Who can point him to me? Not you, Brian. You've seen this before. Okay, so here's Waldo. Okay? You have to believe me. I know it's small. Now do it again. Where's Waldo now? Now you all know it. That's hindsight bias. Right? After you've seen it, after you've seen the adverse event, after you've seen the problem, you go back and say, oh, that's why this happened. Very easy to do. It's the next day doctor thing. So having gone through the hindsight bias idea, we hypothesized that if the cross-covering person is doing something wrong, the more exposure you have to a cross-covering physician at night, the more likely you are to die. So let's look at patient outcomes. Now, if the daytime people are wrong, the more you expose patients at night to a cross-covering physician that may detect errors and solve problems, you may actually decrease mortality. Now, if this is all hindsight bias and no one could figure it out until a problem happened, it should be neutral. There should be basically no effects of a cross-covering person. So we went back and collected data on 1 year of our patients at Sunnybrook, and we could classify all their nights as being cross-covered or not cross-covered. And this is just a very basic table one of those patients. So quite sick patients, our ICU, this ICU mostly has ventilated patients, and about 47% of the nights were being cross-covered. So we looked at the percentage exposure during your first 7 days of ICU admission to cross-covering or not cross-covering. And we compare survivors and non-survivors. And if you looked at the cross-covering, you see that it's exactly the same between survivors and non-survivors. So this data would suggest that all the stuff that we're seeing as adverse events and problems with cross-covering people may be just hindsight bias. Maybe it's all neutral and it's just because you're coming the next day. But this data is actually quite hard to understand because the percentage of exposure of cross-covering actually varies over time. So it may be exposed tonight, maybe not the next day, maybe again. So it varies over time. So this is not really the right analysis to do. So we thought that the right analysis to do was actually to do what we call a time-dependent variable with exposure varying over time for cross-covering. So when you run that, not only it was neutral, cross-covering may be protective for harm, at least in this data set. So this was probably, it's fairly novel and hard to interpret the coefficient of a hazard rate for death on a time variant variable, but at least I'm quite confident in saying that it probably doesn't cause a lot of harm. Therefore, in summary, handovers are very difficult and associated with adverse events. We know that from the literature, it's very clear. Nighttime actions, though, are very different between cross-covering and continuity of care physicians, and patient-centered outcomes do not seem to be adversely affected by cross-covering in spite of all the poor communication that we might do. And I want to add something here that is probably important for the setting. We're actually looking at communication between semi-experienced providers or junior attendings because this is fellows. It might not be the same if you're actually talking about communication between more junior people that may need more information. Thank you.
I'd invite a question or two if people would like to come up. Please do, yes.
Okay, guys, Mayo Clinic, fascinating. Quick question, I don't understand the control group. How can you not be exposed to a cross-cover?
So the control is not being exposed, it's a percentage of exposure.
Oh,
Right, so it's a percentage exposure. So the data here, let's kind of go back on this or no? How do I go back? I don't know how to go back.
I mean,
But
how
the
can
data
you
is-
have a
it's
different
perc-
dose of a cross
it's
cover?
perc-
That's
it's
what I'm
percentage,
wondering,
so
because
there-
nobody can work without sleeping, so you have to have a cross cover. So I'm not sure what.
But there's
is the-
variability on that. So there's a variability that goes from, depending on your length of stay, on the first 5 days, it goes from 0 to 100% of cross covering. Right? So
You
there,
mean if you die in a day, you will not have any cross cover?
yeah, and there may be, on 5 days, you might still be 100% cross-covered if the person that comes at night is always a different person depending on the schedule. So that's why this setting, it's a big limitation being a single-center study, but it's probably one of the few places where you could actually look at this because there's so much variability and it's totally randomly distributed the way you end up being cross-covered. Yeah, so this is, the cross-covering here is by every 10% of cross-coverage that you gain.
No other questions, maybe we'll move on to the last speaker of the day.
So our last speaker today is Scott Halpern. He comes to us from the University of Pennsylvania. His expertise includes bioethics and health services delivery. He's going to bring us home today, and I'm really hoping he's going to tell us that we're not needed in the hospital after 5 o'clock.
Okay. Thanks, guys, and thanks everyone in the audience for sticking it out. So, I think we all believe that intensivists are good, that we help our patients. Pretty much every study, with one notable exception, has shown this, and it was recently summarized quite nicely in a systematic review by Liz Wilcox, that intensivist-led care produces better risk-adjusted outcomes for critically ill patients. Unfortunately, there are no randomized trials of this. So if we're looking for other mechanisms or other factors that might lead us to conclude that there's a causal relationship between intensivist-led care and outcomes rather than just an associative one, we'd look for other things like a dose-response relationship. So perhaps if intensivists are good for patient care, then greater exposure to intensivists would be better yet. Of course, it's also possible that intensivist-led care improves patient outcomes through adherence to best practices during the day, adoption of multidisciplinary care, protocols, you name it, and that there may be either diminishing or negligible marginal returns beyond a certain quote-unquote dose of intensivist exposure. And it's important that we try and figure out which of these competing hypotheses is right, because lots of places in the US and certainly around the world are adopting nighttime intensivist staffing in their ICUs. You can see it's about a third of hospitals in the US, or at least academic medical centers, that have full trained intensivists in the ICU at night, and in most parts of Europe it's actually the norm. So originally there were some quasi-experimental 2 before and after studies, and then a nice study by Alan Garland a couple years ago in 2 ICUs showing, which was a crossover design, which in general these studies showed no benefits to patient outcomes. There were some mixed effects on some secondary markers, things like physician burnout and adherence to evidence-based practices. Then in 2012, the Pittsburgh group published a very nice multi-center observational study using the Apache database, where they found this very interesting conclusion, that all ICUs cannot be considered equally, that in ICUs that have no intensivists there during the day, what we'll call low-intensity staffing ICUs, those that perhaps have the ability to call a consultant intensivist if they want, but transfer of care does not happen to the intensivists, there is a protective effect of having intensivists there at night. But that there's no suggestion of a protective effect on a mortality metric in ICUs that have intensivists there during the day. Another multi-center observational study, which my colleague Meeta Kurlan presented at ATS last year, used a different data set, the Project Impact data set, and you can see here that there was no benefit found in either type of ICU, regardless of the daytime staffing pattern. Now, the conclusion here, I think, is not that this more recent, larger study is correct and the original study was flawed. Rather, I think these discrepant data suggest that it's very difficult to answer questions about ICU-level factors on outcomes using observational data. there's something about ICUs that adopt this staffing model or that staffing model that leads them to that adoption. And we don't really know what those things are, let alone we can't measure them. So it's impossible to adjust for them in our analyses. And it's possible, at least, that these discrepant data are just attributable to residual confounding. So 2 more recent studies from this year. This is Liz's systematic review, which includes the Pittsburgh study and shows overall no favorable effect of nighttime intensivist staffing in ICUs with high-intensity daytime staffing. And then just, I think this month or last month in Critical Care Medicine, this paper from 69 ICUs in the United States Use It group showing essentially the same, no change in risk-adjusted mortality regardless of whether or not docs were there at night. So this will let us to conduct a randomized trial in our one medical ICU at the University of Pennsylvania. So what we're comparing here is a control intervention, which is what we've been using in our ICU for a long time, where we've got in-hospital residents at night. There's at least one third-year resident and at least one second-year resident and a variety of interns. And the daytime attending is on call and available by phone from home, as is the critical care fellow. Or an intervention where we have the exact same resident staffing model at night, and all we're doing is we're adding a body. And that body happens to be one of the normal daytime intensivists, but not the same daytime intensivist who's on service that block. And they're covering typically for one night at a time, although some did it for multiple nights in a row. And the way we randomized the assignment was not by individual patient, that would be very hard to do, but rather by week. And the reason we did this is because what that winds up doing is it better mimics the real life experience if we were to roll out this intervention, because it essentially enriches the data set with patients who have either their entire ICU stay fully covered at night or their entire ICU stay fully uncovered. And that worked, because if you look at our primary exposure, staffing on the night of someone's ICU admission or staffing immediately following their ICU admission during the day, you can see that in the control intervention, the median exposure was 0%, and in the intervention group, the median exposure was 100% of nights. So we have good splay in the exposure variable, randomizing in this fashion. The primary outcome was ICU length of stay, modeled as a time to event factor or variable, and was censoring on transfers to other ICUs, which happen infrequently, and censoring on death, which unfortunately happens quite frequently. And these are the other secondary outcomes. So after looking at the folks who were eligible, we had 1,609 patients, all of whom were randomized because we were able to conduct this study with a waiver from informed consent. And it's important to note that 60% of patients in this study were admitted during the nighttime hours when the nighttime intensivist was there. So if anything, you might imagine that in a setting where there's such a high proportion of patients admitted at night, nighttime intensivists would be particularly beneficial if they're beneficial. So this is the primary outcome variable in all the patients. So here on the y-axis is the proportion of patients who are still in the ICU. And so a rate ratio greater than 1 would suggest more rapid discharge in nighttime intensivist-led staffing. And you can see that the curves are, of course, superimposable. And then when we restrict to just patients admitted at night, which is about 900 of the 1,600 patients, really no change whatsoever. These are the secondary outcomes. Hospital length of stay was no different between the intervention and the control group. And similarly, there were no differerences in ICU mortality, hospital mortality, your likelihood of being discharged ultimately from the hospital to home, or in your odds of being readmitted within 48 hours. And when we look at that analysis, the exposure variable we use is the nighttime intensivist staffing pattern on the night immediately preceding or during your discharge. Lastly, we looked at residents' perceptions of their education during the study, and this is just a snapshot of a few of the questions we asked. So about 2/3 felt like they had enough autonomy on nights when nocturnal intensivists were there. About 3/4 felt like that they were supported in their decisions. In fact, they were more supported in their decisions with the nighttime intensivists there. And about 2/3 felt that the nocturnal intensivists being there at night improve the quality of their education. Now, I don't know exactly what to make of these data, frankly, and if anyone has suggestions, I'd love to hear it. 2/3 of people saying that their autonomy was sufficiently preferred, I don't know if that's good news or bad news. That's 1/3 of people essentially saying that they felt like their autonomy was diminished. And I believe, if I'm remembering Alan Garland's study correctly, they also found that trainees felt reduced autonomy in their population here in Canada. So, 2 key limitations of this study that you'd have to keep in mind in interpreting it. First, obviously, it's a single-center study in a U.S. academic medical center. It probably only generalizes to other academic ICUs with reasonably well-trained residents. When I say this at Penn, of course, I say very well-trained residents. And the other obvious limitation is that we didn't measure all the things that you might reasonably care about, and here are some of the other things that you might reasonably care about. So, what can we say in November of 2013? Well, I think we can say with as much certainty as we can say most anything in critical care medicine that nighttime intensivists do not provide direct patient benefits in ICUs with high-intensity daytime staffing. I think the jury's still out about whether nighttime intensivists provide benefits in ICUs with low-intensity daytime staffing. But you might at least imagine that even if there are real benefits to nighttime intensivists in those settings, there might be greater benefits still to using those same intensivists and putting them there during the day. So I don't know. I've been looking for settings in which to do a randomized trial in a low-intensity daytime staff unit or units, and thus far haven't found any willing takers. So if you're interested, please let me know about that. And then finally, I think we can agree that there's mixed and generally low-quality data regarding effects on trainee education, family satisfaction, provider quality of life, and perhaps some other outcome measures. But I think you at least need to ask the question about if there were significant effects on these sorts of outcomes, would that be enough to motivate the adoption at a policy level when we're talking about an intervention that costs millions of dollars per year for each individual hospital, although from the hospital's perspective, some of those costs are recouped, through, at least in the US, in our warped reimbursement system. But at very least, is costing society a lot of money. In addition, in a world where, or at least in the US, where only 1/3 of ICU patients are ever meeting an intensivist to begin with, and we're going to now try and siphon intensivists so that more of them work in the well-resourced centers, reducing equity of access. And we've got an intervention that doesn't even or hasn't been shown to produce direct patient benefits. So I'm not sure we need to absolutely answer all these questions to make a policy recommendation. I'd be happy to take any questions.
We've got time for a couple of questions. Maybe I'll start off. Scott, what I don't, or I'm having a hard time understanding is how we're so valuable during the day, but yet our presence at night doesn't seem to make that much difference. How do we reconcile those two different sets of data?
Yeah, so I think there are at least two very plausible explanations. So one has to do with what I said at the beginning of the talk, which is that the mechanism by which intensivists improve outcomes is not fully elucidated. So we like to think that it's because of, more experienced decision-making at the bedside, that it's because of, expedited antibiotics in septic shock and things of that nature. Better diagnostic skill, better management skill. But it's also possible that much of the mechanism is explained by intensivists leading a program of care that includes multiple disciplines and includes a structured approach to the delivery of critical care. And that if that's the case, then there may just be nothing else to be gained by having more round-the-clock exposure. So that's one possibility. Another possibility is to think about what our control intervention is. So the control intervention, the way we practice before the study and the way we now practice after the study, because we don't have nighttime intensivists now, is that the daytime intensivist is there for 14 straight days and is on call for all 14 of those nights. And we get called commonly. We didn't show you these data, but the number of nighttime calls, as you might imagine, was much higher during the control intervention than during the control period than the intervention. So it may be, and this relates to Andre's talk, it may be that having continuity of the daytime intensivist participate in decision making counters any benefit to having intensivists there to make expedited decisions at night.
Thank you. I think we have a question at the back.
Scott, so you and I were talking earlier about this juggernaut in American medicine of nighttime intensivists. Despite this data, our professional societies have started in the last 10 years and more making proclamations based on evidence of what we should and should not be doing with respect to ventilators, et cetera. Are we ready with this data for our professional societies to make authoritative statements based on the existing evidence about nighttime coverage?
I think we're getting there, Alan. The American Thoracic Society just approved a working group on this issue, or on physician staffing in general. So there may be Amita Kerwin and Colin Cook, Jeremy Kahn, myself, and several others who are probably in the room are, maybe going to lend some input into this. I don't know what the output will really be, and I don't know what the oomph behind whatever the product is will be and its uptake. But I do think the evidence base for organizational factors in the ICU is coming along, and we're, to the extent that evidence is going to inform policy, I think it's probably going to have an impact in this realm. It's not to say that individual hospitals aren't going to be allowed to make individual decisions, but I think it may have some impact.
Do you have any comments about generalizability to community hospitals where things may be quite different from not having residents available so frequently and that sort of thing?
Yeah. So the randomized trial has absolutely no generalizability to that setting. That's easy. The project impact study that I showed you just briefly by Mita, which had 270,000 or so patients from 100 some odd ICUs. So about 73% of ICUs in that data set are community ICUs, many of which do not have any residents at all. And even in those settings, we could not detect a difference. It's in contrast to the Apache database, where the Pittsburgh paper was, where about only, I think, more than half of the ICUs were academic in that database. So if anything, you might imagine if there's any rationale whatsoever, and I'm not actually sure that there is, to make sort of a cross-study comparison that way, I think at least we can say that there's at least no obvious signal for a benefit in community ICUs, but we're just not sure.
So I think we have time for one final brief question.
It's a very quick question. I was just wondering if you had any incidental findings with regards to the team dynamics on nights with the residents and the nursing RT staffing, if there was any difference in terms of their subjective input in the team dynamics on nights versus a day shift.
I'm sorry, so you're asking about the nurses who are on at night?
No, I'm just wondering if the residents had a different perception of the team dynamics on nights, whether their resources, they felt different based on the team dynamics on nights versus days.
So I'm not sure I fully understood. Maybe the best way I could respond is to say that we're in the process now of coding some qualitative interviews we did with the nighttime nurses about processes of care and how care went on exposed and unexposed nights. And to the best of the ability of these interviews to sort of recreate what was actually going on, there seemed to be a perception of better care coordination, more expedited decision making, better adherence to best practices around procedures and things of that nature. That's qualitative data. Take it for what it's worth. It obviously was not sufficient, even if true, to translate into patient outcomes.
We surveyed our nurses at the end of our study, and the nighttime nurses hated having the attendings there.
So maybe on that note, we'll finish off and thank our speakers for a great set of talks that I think will really nicely lead into the next session, which is going to be Chris Parshram presenting on resident staffing as well.